Okay, hi, this is Elliot Fishman, and welcome to Facebook Live. And today's, I'm looking at my calendar, the 23rd of July, and I hope everyone's doing well. I'm home today. I was worked the last few days, and today I had a bunch of meetings, and I have to finish up an evaluation of a series of 11 grants, and be able to rate all those grants. And a lot of it's on PD-1 and different cancer treatments, which kind of really kind of makes it somewhat challenging. I got my fan club in New York. Whitney's logging in, but they asked me where the new guys are, and that's a different story. I can't tell you about that story right now because we don't have the time, and it wouldn't make any sense. You can see all my guys, some of my older guys in the background, and you could see Paul Simon. Where is it over there? There's a great article this week, not to change the subject, in People magazine about Sandy Greenberg, who's this amazing person who roomed with Art Garfunkel in college, and Sandy just wrote a new book. It's a really wonderful story. His book is in transit to me now, but here's a thing Art Garfunkel sent me. You see that? Art Garfunkel, with Sandy's name on top. Sandy sent it to me a few years back. It's a wonderful story, and I won't. I think you need to read it yourself. So People magazine that came out last week, you can see People online or anywhere else. So that's my plug for People magazine. Maybe it'll it'll extend my subscription for a year or something. So this talk is going to be on the ER and AI. So obviously, we do lots of AI at Hopkins. So we've been working on 4 years now the Lustgarten project, Lustgarten support on AI detection of pancreatic cancer. That's going well. We're looking now from neuroendocrine tumors to cysts, to normal, to pancreatitis, looking at thin and thick sections. We've now collected a lot of patients who were done on scans elsewhere in general, so no longer looking at just thin sections, trying to see how we deal with thicker sections and less quality scans. Also looking at how we can do specifically with scans that were done, patients with a family history of pancreatic cancer, where let's say they got normal scans, then positive, looking at the normal scans, can the AI detect things earlier? We're looking at that, working with folks at MD Anderson, for example, with some of their data, and work with people at Pittsburgh and hopefully people other places as well. So gathering data becomes very, very critical. Um, and so that's great, but where do you think AI is going to be first? And I think right now it's not a matter of where it's going to be first, but where it is first. And I think that's in the emergency room. We wrote a couple articles this month, literally, that just were published in Emergency Radiology, as well as some other people wrote articles talking about AI in the ER. And it's really interesting, and I wrote down a few notes here, so I don't want to forget my notes. But if you think about it, how can AI work in the ER? So let's think about it for a second, looking beyond radiology and then looking into radiology. So AI can be used to look at patients coming into the ER and try to triage them. AI can look at your symptoms and kind of triage you into different subgroups of urgent and less than urgent care. That can be very important in a very busy ER. You want to be taking care of the more urgent patients than the less urgent patient. A person who has just some vague abdominal pain that's been there for 3 weeks probably is not the same patient who has severe nausea and vomiting and is hypotensive. So AI can be used to really triage patients and then perhaps triage them to the right person. If it's cardiac, you want to be seeing someone who's from cardiology versus someone from GI. You also then want to be able to select the correct exams. Now, in the ER, there's often a tendency, let's get an ultrasound, a CT, maybe an MR, maybe this, that, and the other. So what exam should be done? What's the best bang for the buck? If you're having right lower quadrant pain and you're 55 years old, might be different than if you're 25 years old, but is CT the right study to do? If they're very young, should you do an MR? What's the best study to do, and how do you do the study? Do you do oral contrast? Do you do IV contrast? Do you do single phase? Do you do multiple phase? What is it you do? Well, I think in that regard, we could use AI to help us optimize and choose the correct answers. So now you're going to say, we're seeing a patient, and we think it's acute, a short of breath, They meet some of the criteria. Let's get a PE. So now we're going to send them to CT, get a line placed, prep the patient, and we do the study. Now, if you're a typical hospital, in most cases, the studies in the ER, depending what time of day it is and how busy people are, will get read within an hour. That's pretty good. We all know that if something's really urgent, like there's a trauma case, you'll do it quicker. If someone says, hey, patient has chest pain, Elliot, what do you think? You'll do it within a few seconds. But one of the things AI has done, and we spoke about this in a couple of the articles, is the companies that are developing AI that have FDA approval. So there's a few different companies that AI Doc is one of them, Zebra Technology is another. And if you look at the apps that they got approved, they're all essentially ER acute apps. So they got apps to look for intracranial bleed. They got apps to look for pneumothorax. They got apps to look for pulmonary embolism. They got apps to look for pneumoperitoneum. They got apps to look for osteoporosis and collapse, which maybe is not as acute, but is important. So you see a lot of the apps are these very acute setting apps. Now, of course, the FDA, which has been good about approving things, also makes it clear that you need to read the study. It can't be that the AI is doing the study and no one looks at it. What they're really doing, and this is the first level of AI, and we spoke about this, is AI is becoming a triage study. What does that mean? You get a PE study, it goes to the list. But you get a brain study, look for a bleed, it goes to the list. But what you're using AI for is AI is being used to see what patients are positive. So for example, if you look at every case suspected bleed with CT, then AI will look, and if it sees something that looks positive, they move it to the front of the list. So you're going to have to read it anyway, but what AI has allowed you to do was to prioritize. And there's been a couple of articles that make the point that by prioritizing, you read it about 35 to 45 minutes faster. And with brain bleeds, for example, time is brain. So you need to really be good at doing things. The same thing with PEs. Study sits around. Well, you want to be acting on that study. You want to be admitting the patient, treating the patient, whatever you need to do, you want to do it as quickly as possible. So even though the apps as they stand now are not to replace the radiologist, and they probably never will be, it's to really triage. And the ER triage is so critical. How do you do things faster? How do you choose the right patients? So I think that's going to be very, very valuable. And there's been several articles that show it has great value. Now, is there a downside? Well, if it says there's a bleed and you don't find the bleed, well, you have to read the case anyway. That's not a downside. But a couple of the articles have shown that at times the computer picked up a bleed that the radiologist would have missed. So not only is it prioritizing, but it's increasing your accuracy. I think that's very good. And if you think about it, things like pulmonary embolism detection, pneumoperitoneum detection, people do miss things. Now, the computers are not going to be perfect. They may be overcalling as well. And computers do have a problem, particularly if the protocol is not that good. We kind of know if someone breathes or the injection is not that good, the timing is not that good, we kind of do the best we can. The computer has a bit harder of a time with that, but it's something, again, that they can be used and used well in that regard. So that indeed is happening. Now, what else? I think then also you say, what about management of patients? So once you see something, let's say you do see a bleed, then the patient, depending on what you see and what the history is, the management decisions will be made. Where does the patient go? Do they go to angiography? Is it a bleed like an aneurysm you're worrying about, or is it a tumor? Then you're going to neurosurgery, neuro-oncology. So it looks to me like AI is going to fit in all the aspects. And it's really, in my mind, if it's used correctly, it's very, very positive because what's the downside? There's no downside. All you're trying to do is expedite and treat the patients faster. The other thing is with AI, you have a lot of experience. You could train, I think the AI doc one was trained in over 100,000 brains. I don't know how many thousands of bleeds. But again, the ability to do things better, particularly with people who have less experience, and particularly people in the ER where it can be very busy. Think of all this COVID-related stuff that goes on now. Everyone's tightly staffed. It's very busy. The techs are busy. The docs are busy. Nursing's busy. Everybody's busy. How do we still treat the patients really well? I think that becomes a big factor. So that's very, very important. Let me look over here at my list here. Oh my God, B Mudge has cleaned her desk out. B, I think I've told you before, who's been our chief tech, and I worked with B for 40 years. B's been chief tech for probably most of those years, probably 38 years or so. She decided to retire. I don't know why, but she's retiring, at least temporarily, I guess, on July 30th. So that's going to be a major loss for Hopkins. And she got Sandy Greenberg's book, so she started reading it last night. And you can see Ava's in, right? And Ava is my neighbor, and Jim, my neighbor. And Ava and I walked this morning. It's like 97% humidity. We walked. She walks very fast. I stay in the back. It's kind of in case any Indians or wild animals come or something. But I'm kind of a little bit behind typically. But and I agree, we're going to miss B. Hello from India, Kapil, and then there's B answering back, and hello from Guatemala, and everybody is different places. I think the COVID thing has brought people in some part closer together, and everyone's kind of figure out where the best place to be is. I saw a good article from Bermuda. Bermuda like has no numbers. I think that's where Mayor Bloomberg is, playing golf, and in Bermuda, probably a nice place to be. Though I'm sure it's hot, though I have to admit, those of you on the East Coast, and probably those of you on the West Coast, know it's been a really hot summer. Here we're in the 90s every day with 90 humidity, and my phone the other day said it felt like 108. So that's going to be an issue. So going back, let's discuss a little bit more about AI. So one of the things, I'm going to ask a few questions, and people can have answers or just think about it. One of the questions I have, so if AI is now being used in the ER, and there's been a number of really good articles showing its value, the question is, when do you have to use it? So I mean, right now, some places are buying it and they're using it. And that's a good thing. They've published really good results. And perhaps they can advertise, hey, our hospital is better than your hospital because we do this and it's better for you. That would be a valuable thing, I would guess. But my question is, from a legal perspective, if somebody now would say, hey, if you would have used this AI software, you would have picked things up earlier and it would have made a difference. It's not the standard of care. And you only sue on the standard of care. You can't say, well, this is available, we should use it. You can't do that. You got to only sue on standard of care. So my question is, what is standard of care, and when does standard of care change? That's a very interesting thing, because it needs to have a lot of experience, and people generally need to say, if you don't use it, you're making a mistake. Kind of the idea about doing a CT of the abdomen versus laparoscopic surgery, or open surgery, looking for a cause of abdominal pain. That's what we used to do. We used to classic open surgeries, right? Then CT replaced all of those things. But how is that going to happen with some of the ER apps? That's a good question, because we, as the same thing, we do pancreas. We need to be good, so we have really good numbers, but what's it going to take for people to actually use it? That's always going to be a good question, because it's always very hard to get people and convince people to move over, because there's a cost involved, there's training involved. So that's a very, very important thing in terms of ER, and it's very important in terms of every app. So the question is, does your hospital be at the front end of things or at the back end of things? Now, unless it becomes legal importance, it may not matter in terms of people having to buy it. I was supposed to give a talk in March in Washington at one of this quality assurance meetings, just about that topic, about how would we know when AI has to be used as opposed to, gee, it's nice, it's something you can do. I think that's going to be very, very important to really think about. The other thing to think about is, what are you doing, you yourself, in terms of your group and your department? How will you decide when it's time to use AI? Is there something that needs to be done? Like, are there certain articles you want to look for? And once there's a preponderance of information that shows it to be better, you'll do it? Is that what's going to happen? Or is it a lawsuit that'll make it happen? I don't know the answer, and I'm not trying to get involved with any legal matters, but it's an interesting thing to me. When is it when you have to do something, as opposed to the ability that you could do it? And so cutting edge places, it doesn't mean you're big academic institutions. Some of the private groups are very cutting edge, and sometimes private groups with a lot of technology adopt it and use it way before academic institutions, because academic institutions at times do a lot of fumfering and thinking and overthinking. And groups, someone says, okay, let's buy a company X, and that's the way it goes. So that's a good question to me, because it does seem like some of the stuff for the ER setting, again, not picking any one company, is ready for prime time, and perhaps is something that can be used. That's interesting. The other thing with ER software, I've seen both from GE and from Siemens, some software that does some core things like measuring the heart size, measuring, looking for lung nodules, looking at the ribs, looking for fractures. So again, it's not creating a report, but it's doing some functionality. So I think the ER is a great place, because what the diseases you're looking for, the things you're looking for, are in some sense infinite, but are in some sense finite. So if you're looking at an MVA, you want to be able to look at all the bones, find all the fractures. You don't want to miss a fracture. You want to look for bleeds. You don't want to miss a bleed. You don't want to miss a pneumothorax. You don't want to miss a vascular injury. So all of those things, potentially, you can imagine AI just coming in there and sucking up the data and basically coming out with really strong information. So I think that part becomes very important, and something that needs to really be driven ahead. And I think you're going to see articles, and you're starting to see articles, that really address that on a routine basis. There's an article just published in Pancreas about Pancreas AI. So we are seeing more articles coming out. But again, there is a long distance between someone publishing an article of 50 cases, perfect protocol, perfect scenario, and the results being good, versus a typical hospital where protocols are so-so, patients are variable, technology is variable, they don't have the latest and greatest scanners. How will the AI perform? I think that's going to be, to me, the biggest challenge. And then, of course, the challenge of who's going to pay for it. I know with mammography, you get a few extra bucks when you use AI for looking at the breast, but it's really the amount of money that doesn't impact anybody in terms of being so small. It's like $5 or $10. So people are doing it because it's expected to do it. I want to know when it's going to be part of the bill. Now, people talk about AI. It's kind of like Intel Inside. You remember those little labels, Intel Inside? And then at some point, everything was Intel, so you didn't need a label. I've read an article, someone made the point that the way you can tell AI really works, and it's critical, is when people don't say, I used AI, okay, because it just needs to be built in. And that leads me to one last question. I just read an article, and little in the last 48 hours, and I'm just trying to think where I read it, but it was from England, and they were looking at AI, where they're using it in some of the hospitals to triage patients, and they're getting really good results. Okay, so the AI seems to be helping them and getting good results. The question came up from an ethics perspective. Do you need to tell a patient you're using AI in making decisions for their care? And you can imagine some people said yes, because if you're using AI, you should tell the patients may not be comfortable, maybe they will be comfortable, but you got to tell the patient. And then there's another group of people who said, listen, I do a lot of things I don't tell the patient. The patient comes to me with a symptom, I come up with a diagnosis. Whether I looked up in a textbook, whether I asked two of my friends for a second opinion, whether I thought about it a lot, whether I had a prior case, however I did it, the patient wants to know from me how I treat them and what's wrong with them. They're not asking me, tell me now, how did you come up with this diagnosis, Sherlock Holmes? They're not asking you that. They're asking you for the diagnosis and please treat me. So the philosophy is, if I'm using AI, if I think the AI is really good and it's going to help me, I should be using it. Do I need to tell a patient I'm using AI? Well, what does that mean? The patient is going to say to me, I'd rather not have you use AI. Or they were saying, well, maybe you need to get permission from the patient to use AI. I think that makes no sense at all, because if I do multiplanar reconstruction, the patient didn't tell me to do that. They asked for a scan to rule out a pancreatic mass. I need to do everything I can to make certain there is or isn't a pancreatic mass. Then I need to do to be certain what the mass is, whether it's a serous cystadenoma or an adenocarcinoma or an IPMN or a CTisus, whatever it may be. That's my job. That's what I get paid for. And I need to give the right answer to the patient. How I get to the right answer, the patients typically aren't concerned, and it really doesn't help them. What they need to know is I can get the right answer. So it's an interesting thing with AI that all of a sudden people are asking, do you need ethically to report that you're using AI? And of course, like anything with AI, there are always two answers, two sides to the question. Of course, usually it's four sides. Yes, no, maybe yes, maybe no. That makes four. So it's kind of interesting, and I think it's something to really pay attention to and really kind of come up with your own thought process, what you're going to do. So that kind of takes me to my time. Meg Fines congratulates B. Meg is in New Jersey after leaving Hopkins in December. If anyone has any quick questions, this is a good time to ask. But if you don't have any quick questions, then we'll say thank you for being here. I hope everybody is safe. I hope everybody is working hard and enjoying themselves in this most difficult of times. And with that, have a great day.